getting to have this conversation and hear about some of the investment work already underway. I was leading Global Health at USAID, and the way I think about health equity and the protection of primary care is by starting with recognizing that there has been progress, but the progress left is still very deep. 60% of deaths in 1990 were in women under 50 and children under 5. That has advanced to the point that it is now 40% of deaths are in women under 50 and children under 5. During that same period, however, in places in the continent of Asia and Latin America, those numbers went from 40% of deaths to 10% of deaths. That is the definition of health inequity. One of the critical other sources of inequity is that cannot be solved when Africa has 1/4 of the global burden, but only 4% of the health workforce. And the most critical element of the health workforce is the primary health component. The evidence is that if you have health systems that are rooted in strength and primary health care workforce, that is what produces a lower mortality rate for women and children, improved equity, and also improved gender equity, as well as increased cost efficiency. Now, what do we mean by saying rooted in primary health? It's not simply that you have a primary health trend that people can go to. The critical element is that you have a community-based workforce who are able to reach out and touch every home in the community, ideally in the country, at least once a year. But that community health workforce that reaches out is not doing it just for, I get to run in some sense, but we have a TV program, our malaria program, our electric outpost program, we have our maternal and child health efforts around childbirth and nutrition, et cetera. But all of them only end up working through the same workforce. That workforce is the community-based workforce at every home. It's trained at least 12 months when it is working best. When it is not just having in one area, but it is what we call polyvalent. And they're salary. So they're paid in a reliable and secure way. And they're not on their own. They have to be connected to a higher level primary health clinic system where the problems that they can't address be faced in a small community can be elevated into a functioning system. Much of the benefit that they bring comes from touching people who've been lost to the system and moving them into a system that is functioning. Evidence that it has remarkable effects. But USAID, our funding comes in these vertical projects, but we have been committed to continually reducing that contribution to deaths of women and children as an indicator of the health of the total health system and workforce for everybody in the country. It's also important to recognize that 70% of that healthcare workforce that touches the community are women, and this represents a vital employment opportunity as well as a way of equity economics. We announced at the Activity Summit just a couple days ago a commitment to accelerating our investments in the primary healthcare workforce by coordinating with all of our investments in USAID across our multiple offices in these areas, with the President's Malaria Initiative, and with the Global Finance Facility, which works on advancing women and child survival with World Bank. And we're doing it starting with 5 focus countries where we want to coordinate our investments in order to enable these pathways. And those starting countries are Cote d'Ivoire, Ghana, Kenya, Malawi, and Nigeria. The efforts have been partnered around the investment cases that the Ministry of Health already made with the World Bank. So we want to be coordinated. In addition, I want to thank John Henderson for also committing that PEPFAR will work with us in Malawi to also bring PEPFAR funds around this coordinated effort. Take the example, for instance, of young women receiving contraception, long-acting contraception, but not being assessed for risk and provision of HIV. And therefore, they're coming back with HIV. And then we're seeing HIV patients who are being given PrEP, or not being protected from HIV and being given PrEP, but coming back with unintended pregnancy. And the chance to work together so that we're ensuring that the full spectrum of services are being connected across all of our programs, but in ways that are also I'll also add that we announced that at the South Africa Summit just yesterday, a public-private partnership along the lines of some of the ones that we've talked about with the financing vehicles. USAID put in an initial $1 million in catalytic funding, which leveraged $10 million in development finance corporation funding, which leveraged so far $50 million in the first round of investment for a public-private investment partnership focused on innovation, women-led, majority women-led innovation in advancing health equity, especially around healthcare.
That's a great announcement. Yes, so thank you.
We're excited to be able to do it, and to have $1 million leverage that far from the USAID is also very good. So we're excited by the work.
Thank you so much.